Members, today is Wednesday, April 2nd, and the time is 1 sharp. I call this meeting of Health, Finance, and Policy to order. Members, we have a quorum. Representative Knudsen moves to approve the minutes from Wednesday, March 2026. Is that correct, Representative Knudsen?
I do, Chair.
Oh, thank you. All those in favor say aye. Aye. All those opposed say nay. The motion prevails and the minutes are approved. Okay, members, we have a super full agenda today, so we're going to try to rock and roll. I've been in touch with all the members who have bills, and I'm giving a lay of the land. So also, leadership has agreed to extend our hearing into the evening after caucus. Should we run out of time, and we would be back in this room at 6:45. So our first bill up is House File 2769. Our goal is to stay with about 7 minutes on this bill, and our intent is to lay this bill over for possible inclusion. The chair moves to adopt the A1 amendment. Are there any questions? Okay, all those in favor of the A1 amendment say aye. 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 All those opposed say nay. The motion prevails and the A1 is adopted. Representative Dotseth, introduce your bill and then we'll go right into your testifier. 7 minutes.
Thank you, Mr. Chair. Representative Jeff Dotseth, House File Number 2769, Green Burial. I will actually, it's a bipartisan bill that we'll be discussing today. It is actually one that is, just for clarity, we've actually been working with all the various communities and players in regards to this bill, and don't appear to have any opposition to it, and we've been speaking to all stakeholders as we move forward. With that said, I'm going to turn it over to my testifiers and yield most of my time to them. Mr. Chair.
And the testifier, please introduce yourself, and we ask you to keep your testimony down to two minutes, please.
Thank you, Mr. Chairman. Mark Thel, former county commissioner, former soil and water supervisor, and a longtime organic farmer. This bill was originally drafted from the moratorium, and there was a result of the moratorium that come by with the study that was produced by the health services that put up enough of recommendations, and because that channel of getting the health committee report back to Senator Rarick so we could get it through Senate Council to keep the ball moving. There's been a few little adaptions, but it's moving forward here in a very quick order. So thank you for doing this today. But there's a few things that I particularly, there's a few concepts. We're 100% for this natural organic burial process. I think we're going to go back to that as time moves on for the health of our soils and everything else that we do things. So this is a forward-looking process of identifying what soils are good for decomposition of the human body. As an organic farmer, I know exactly what it takes to make good compost. We do bury animals on our farm, so we try to follow those different scripts of 4.5 feet in the soil, so we don't have animals being dug up by wildlife. We're trying to do our best with trying to manage our farms in a great manner. In this cemetery coming in with these rules, as former county commissioner, creating more tools in the planning and zoning compulsion. That's what these recommendations are helping the county to do. So any questions, I can do that, or we can do them at the end, whatever, Mr. Chairman.
Okay, thank you. Please state your name and again, 2 minutes, please.
My name is Dan Reed. I'm the 5th commissioner from the 5th Commissioner District in Carleton County, southwest of Duluth. It's interesting that we're approaching, before this discussion started, I as a child always heard, living in a rural area, well, that your great-grandfather is buried under that elm tree over there, and that's why we don't clear that piece of ground then. No stone, nothing, just he's there. It obviously was a green burial. in 1892. Here we are again, more population, more concern about influencing the water and keeping our whole living area so that we can all live there healthily. And so the guidelines that have come through from the Minnesota Department of Health, we agree with and hope that they can be used for when changes occur on the county level in the future. Thank you very much.
Thank you. Just members, right now, what's being passed out is a refresh agenda. There were some things that was cut off from the original agenda, so just, that's why that is coming to you. Now, and thank you, testifiers. We turn to the public. Is there any testifiers from the public? Okay, seeing none, turn to member discussion. Representative Hewitt.
Real quickly, Chair Backer. Again, this was my bill in the past. I'm glad that it's been worked on. It's really in good shape right now. It followed the department's recommendations. I look forward to the future of working on this, and maybe Rep. Dotseth wants to be the new funeral guy, so this is good.
Okay. Representative Liebling, I guess you're going to be the funeral gal.
Yeah, well, I think I already am, Mr. Chair. Thank you. So I just thank you very much for this bill. I really appreciate when I saw it and I saw that it implements the report and everything. I think that that's really great. I'm really happy with that. I'm really happy that we can go forward with green burials and natural organic production and all those things. And thank you to the two gentlemen who testified. My one little question is about the part that changes the required payments, the Section 3. Representative Dotseth, could you just explain what that's doing?
Representative Dotseth.
In regards to payment, is what that was?
Yeah, Mr. Chair, Representative Dotseth, it's Section 3 of the bill. It changes from 20 to 25% of the proceeds of all the sales of the lots that have to be retained. I just wondered what that's doing.
Wonderful question. I think the main reason why we actually put a number in there was concerns if there were default of, I'll just say of a cemetery, that there was actually some guidelines put in place for some sort of guidance on that, in that type of situation that were to take place. Representative Hewitt, I see you've got a comment.
Representative Hewitt.
Thank you, Chair, and real quick, Chair Liebling. What this is commonly done in cemeteries where they do retain a trust fund that if the cemetery does default in any way or something happens there, that this money is put aside in a trust fund that would basically continue the perpetual groundskeeping and stuff like that of the cemetery. So this is common cemetery language. I hope I answered your question.
Well,
Chair
Mr.
Liebling, go ahead.
Thank you. Well, that's fine, Representative Hewitt. It's silly. I'm sitting next to you here having this conversation. But I'm just wondering why the change in the number. Is it just because it's going in the bill from 20% retention to 25? And I don't have any personal problem with that. I just wondered about it and just wondered if, you know, all the stakeholders who would be subject to that change are okay with it.
I'm going to call on Ms. Clarkvis for clarification research. Go ahead.
Representative Liebling, that section was deleted in the amendment. So that section is not going forward.
Perfect. Thank you.
Okay, thank you. Representative Dotseth, close.
As you can see, this is a bipartisan bill. I did not start out thinking I'd get involved in green cemeteries, but you never know what you run into in the legislation. I appreciate Representative Hewitt for leading the charge on this bill 2 years ago, where we were able to get the moratorium in place. And now, after the studies came out, these are some guidelines that we're actually working with to proceed forward. I appreciate your consideration of this bill, and as we move forward, thank you.
Thank you, thank you. House File 2769 is laid over as amended. Representative Virnig, please come to the table. As she approaches, the representative approaches, the chair moves House File 2489 before the committee with the chair's intent to lay the bill over. Go ahead, introduce your bill.
Thank you, Chair Backer, Chair Bierman, and members of the committee. Before you is House File 2489, a bill brought forth by school nurses. This bill is designed to enhance the safety and well-being of students susceptible to severe allergic reactions by ensuring that Minnesota schools are equipped with the necessary resources and protocols for the effective administration of epinephrine. Currently, districts may stock epinephrine injectors, or EpiPens. But as with all technology, things have evolved, and we now have pre-measured epinephrine administered nasally. This bill does two things. It removes the language specifying EpiPens, or epinephrine injectors, and replaces it with epinephrine delivery system, basically an FDA-approved single pre-measured dose. This allows for the law to be nimble to accommodate current and future delivery methods. It also provides districts with the ability to obtain standing orders for distribution and condition-specific protocol from the Minnesota Department of Health. Some schools have struggled to obtain standing orders and condition-specific protocol, a requirement to stocking epinephrine. We modeled this after the standing orders for the distribution and condition-specific protocol that was established for naloxone. We know that minutes matter, and this will provide better access to districts across the state. With that, I will yield for any questions.
Okay, we have no testifiers. Is there anybody in the public that would like to testify on this bill? If not, okay. Members, questions, discussion?
Good bill so far.
Representative Keeler.
Thank you, Chair. Thank you, Representative. This bill came to us in education policy, and we had the cutest little supporter and the testifier, and I want to talk about, I mentioned this in policy, but this is about a nasal spray that, that our youth can have in school. And not very often do I go back home and get pulled over in the, not pulled over, get stopped in the grocery store and talk about how great the work we're doing. And I had a 10-year-old stop me in the grocery store in Moorhead and say this would be life-saving for her because of how she has to respond so quickly to allergies. And so I just want to say from my community, it's been pointed out that this is a very wonderful bill, easy to implement, and I'm happy to support this. Thank you.
Thank you. Representative Carroll.
Thank you, Chair. And I just want to thank the author for bringing this bill. I have a daughter who has severe food allergies, and at her early, and she still carries an EpiPen. She's had to do it from a very early age. And, you know, there's a lot of self-consciousness about doing that, but nonetheless, she does it. I appreciate you doing this. It'll help.
Okay, and then finally, Representative Gillman.
Thank you, Chair, and thank you so much, Rep. Virnig, for bringing this bill. One question I had is just, I've bought many EpiPens. I have a son who also has anaphylaxis to certain things, and he could even touch it and have that. So the cost difference, do you know cost-wise and expiration-wise, are schools, you know, just, do you know what the cost difference is between an EpiPen, because it usually comes in a two-pack, compared to the nasal spray is? I'm just curious.
Representative Virnig.
Representative Gillman, thank you for asking that question. I do not, but I will get back to you.
Okay,
Okay, thank you.
thanks. Yeah, thank you.
Yeah, it is a good idea. As an EMT, anything we can do to help people survive without ambulance delay, that is great, and help with respiration. So with that, the chair lays over House File 2489 for possible inclusion. Thank you, Representative. We are turning this over to Vice Chair Nadeau while I approach the table.
Got all night.
I got all night. We're in no rush to go anywhere.
7 minutes.
Oh, let me start the timer.
We have support.
The chair moves House File 1935 before the committee with the chair's intent to lay the bill over for possible inclusion. Representative Backer, please introduce your bill.
Thank you, Vice Chair Nadeau. What House File 1935 does, it seeks MA rates increase for a type of a heart monitor that is a better option for some patients. We know our heart's important for circulation, for breathing, and for life. So it really gives a better patient experience for those who are needing help to be able to continue with their life. So with that, we have 2 testifiers, I believe.
Just one.
We have 1 testifier on Zoom, and so let's turn it over to the testifier, please.
Hi, good afternoon. My name is Elizabeth Stoll, and I work with Baxter Healthcare Corporation. Thank you for having me today. Just want to, I know you guys have a summary sheet of kind of what the bill does. I think it's pretty clear in there, but I'll just go over really briefly what these echocardiograms are and how they work and how they're different than the other products that we are looking to have reimbursement changed for. And before I even start, I just want to mention that we are not the only provider of this long-term ECG. There are plenty of other providers that would also benefit from this increase, so I just wanted to put that out there from the beginning. Basically, when you have an arrhythmia or heart condition that feels like your heart's not beating correctly, the doctor will prescribe an ECG. And normally, the first entry level is called a Holter monitor that only lasts for 48 hours. And it has all the leads and the guard and the wires and the box that you have to stick it in. You've probably seen people or had one yourself. They're a little more difficult to wear, especially for certain populations like children. You can't bathe in them, things like that. And they only last 48 hours. And so a lot of arrhythmias are missed during that time period. A lot of people's arrhythmias happen over infrequent amounts of time infrequently and over longer periods of time than 48 hours. So there are other options on the marketplace to catch those people that may need a longer monitoring process. And that's what this long-term ECG is. And our product looks like a pen like this, and it sticks to the chest right here, and you wear it for anywhere up to 2 to 15 days, depending on what your doctor would like you to do. And once you're done wearing it, you take it off and you mail back in the part of the patch that has the data in it, and you mail it to Baxter, and then we read it and work with the cardiologist to get that information to him. And so it also has the benefit of not only being a longer test, but it's also got the benefit of a mail-to-patient solution, eliminating needing to go to the doctor, reducing non-emergency transportation for Medicaid patients. So there's other things that are positive about this option, as well as it. You can bathe and children can wear it, and there's a lot of other great things. It also reduces the amount of missed arrhythmias, which translates into saving money, as well as repeat Holter monitor prescriptions when the arrhythmia is not caught and they keep having to prescribe the Holter for another 48 hours. So right now, this product is covered under Medicaid, but it's really, really low. And for the people to enter the market, for us to enter the market, we are requesting that the rate be raised. And it does not cost very much money. It actually, if you did dynamic scoring, it would save the state money, but I think it's a 2-year cost of $300,000 for 2 years if you were to pass this vehicle, not incorporating any of the added benefits of having the product on the market as well. So, thank you.
Thank you. Chair Backer, do you have another testifier?
We do not. The other person is available for questions.
Awesome. With that, is there any members of the public that would like to testify on this bill? Seeing none, I will close public testimony, open it up for member questions. Representative Hewitt. Oh, you didn't raise your hand?
No.
Sorry.
Good bill, though, good bill.
Representative Liebling.
Thank you, Mr. Chair, and thank you, Chair Backer. Something like this certainly is a worthy thing to raise the rates, and there are a lot of things, obviously, in our system that are underfunded. We know that. There are other bills around to raise rates. And I'm just curious because you're the chair of the committee, or the co-chair anyway, and we have a budget target that, if I'm not mistaken, it's a cut target. So we have to cut 50 million. Is that correct? I don't remember the number. I think it's 50 million in this biennium and 300 million in the tails, if I remember right. Please correct me if I'm wrong, but, pardon? Oh, 175 in the tails, okay, well, that's not
Yeah,
as
don't give
bad.
us a heart attack, we might need these.
Yeah, well,
I'm sorry.
yeah, so Chair Backer, I mean, I'm just kind of wondering, you know, why are we hearing bills that would cost money? I mean, what is your intention with this bill? Are you planning to try to fund it by cutting something else? I'm just really curious because we have very little committee time. We don't have money to spend, clearly. We're going to have to make some really difficult decisions. And, you know, I'm just really wondering why you're hearing bills that are costing money. Thanks.
Thank you, Chair Liebling. Good question. 50 million here, 175 in the tails. This is something that Co-Chair Bierman and the Vice Chairs will be discussing. There are times it makes us smart to invest a little bit to give a good long-term savings. I see that in this bill, and we'll take it back to our committee of 4 and see what our priority is. This makes sense because it's going to help to save lives. I know that's important to a lot of committee members, and that's why I brought it forward. Is it going to be easy? As you have been in my position many years past, you know it's not easy, but we do take priorities. This is something that's important to me, and that's why I wanted to hear it today. So good question. Thank you, Chair Liebling.
Members, any further questions, comments? The chair lays over House File 1935 for possible inclusion in the omnibus bill. Thank you, Chair Backer. Let's move on to House File 2604.
There you go. Okay.
I will move House File 2604 before the committee with the intent to lay the bill over. With that, Chair Backer, please introduce your bill.
Okay, thank you. House File, I think I have the wrong number on my notes, make sure, 2604, I do. What it simply does is it asks the MCOs to verify that there's an enrollee that's a live person who resides in the state by asking them to respond and attest that they live in Minnesota at a specific address and they're requesting Medicaid service. This does not demand a redetermination of eligibility. This simply asks the MCOs to reach out to hear from the enrollee. So we're trying to be creative to make sure that our scarce public dollars, because as we're aware of, we're facing cuts, are going to the right individuals. We see this especially on the border community and so forth, because we have people who have a Minnesota, they get a Minnesota address, but they live in South Dakota. So a 2% withholding incentivizes the plans to do that, and if the plan cannot find the enrollee, then the state will stop paying for those services. Under our presumptive eligibility requirements in Minnesota, they would immediately become eligible again if they seek care. And with that, I turn it to our testifiers.
Excellent. And who is it? Matt Dean. Ex-Representative Matt Dean, thank you for coming back. You used to chair this committee, I think.
Those were the days, huh?
Please introduce yourself and proceed with your testimony.
Thank you, Chair Nadeau and members. My name is Matt Dean with American Experiment, and it's a pleasure to be here today. I've included my testimony in your packets, so in the interest of not having to come back tonight, I will limit my testimony to a very little couple points. Number one, the amount of money that is involved with paying for people who live in another state, do not qualify because they make too much money, are dead, or are signed up for more than one program is significant. And if it's, you're going to be dealing with that either this term or next term, and probably a good idea to get ahead of it. Just how big the scale is on that. Minnesota spends more than 47 other states on Medicaid, and for the disability portion of Medicaid spends twice as much money as the average state. So in last year, we had about $50 billion that went out for Medicare that was for ineligible folks, according to the GAO. We have about 1.8% of all Medicaid patients nationally. So that works out to about $1.2 billion a year just on the Medicaid side that the federal government says is for folks who don't qualify. So what this says is that if you are receiving this, that you need to check in, say, I'd like to stay on Medicaid, I live in the state, and this is my address, back to the provider. And the provider's probably going to say, well, that's not our job. It's actually the state's job to make sure that people are eligible, which is true. And what this says is that the person that we're giving you a check on behalf of actually lives here, is alive, and lives at an address. So that is a very quick synopsis of my testimony. I'd be happy to answer questions or follow up with any member afterwards. So with that, thank you.
Thank you. And next up, Chelsea Olson. Please state your name and proceed with your testimony. Thank you.
Hi, my name is Chelsea Olson with the Minnesota Council of Health Plans. Thank you for the opportunity to testify today with our concerns on House File 2604. We share the author's concerns over ensuring only eligible Minnesotans are receiving care through the state's healthcare programs. Council members strive to support program integrity and efficiency in serving this population. However, we do have three main concerns with this bill. First, the Minnesotans receiving Medicaid and Minnesota Care already face substantial hurdles in receiving health care, from the forms for coverage being paper-based, to delays in processing at the counties and DHS, to language barriers and everyday life factors. This bill requires yet another step for these Minnesotans to access the health care for which they are eligible. And we are concerned that it will result in otherwise eligible Minnesotans delaying needed care only to later be re-enrolled with costlier conditions. Second, eligibility verification is currently the responsibility of counties and DHS, and they perform this check prior to enrollment with an MCO. We understand the author's intent is to have the MCO re-verify eligibility. We recently went through a significant undertaking with DHS and the counties to process redeterminations after the end of the PHE, and much was learned during this process, one of which was emphasizing the negative impact that antiquated systems and paper-based applications had on this process. Rather than assigning new tasks to MCOs, we would recommend modernizing the counties and DHS systems to be able to process applications in a more efficient and effective manner. Third, health plans are already subject to substantial cost shift, including a state fiscal year payment delay and withheld payments that combined totaled more than $1.5 billion each year as of 2023. This language would add to the payment shift and would have a detrimental financial impact on health plan solvency. Thank you for the time today, and we look forward to working with the author to support program integrity and efficiency in serving this population.
Thank you. Is there anyone else from the public that would like to testify on this? With that, I will close, seeing none, public testimony, and we will move to member questions, and I'm going to start with Representative Elkins.
Thank you, Mr. Chair, and I'm sure I'm going to have a follow-up to my first question, but I just want to make sure I'm understanding correctly that we're talking about having enrollees fill out a paper form?
Representative Backer.
Yes, there would be that type of verification.
Representative Elkins.
Okay, so thank you, Mr. Chair. I'm a member of the Fraud Prevention Committee, and this is a subject that we spend a lot of time on. But coming up with having an attestation on a paper form is not an idea that any of the members of that committee would have brought to the table. We just went through a huge Medicaid unwind, as it's referred to, that took 2 years because it all had to be done on paper. The ideas that we're coming up on the fraud committee don't have anything to do with that with paper, but we're spending a lot of time on the subject of eligibility verification. But I see this as a huge step backwards.
Would you like to respond,
Yeah,
Chair Backer?
This is starting to talk about this process. We do know that there is abuse and misuse in there. So I'm very open. I've been talking to the plans the last couple of days on other ideas on that verification. We need another set of eyes on this, and that's really what it is, because this is taxpayers' dollars, and what we're really getting challenged with is that there seems to be a robot type of approach at the agency of just moving people through instead of finding ways to make sure the Minnesotans that need this coverage, we always talk about the rates are so bad, that the Minnesotans who need this coverage is getting it.
Thank you. Representative Bierman.
Thank you, Mr. Chair. Thank you, Chair Backer, for bringing the bill for us to have some discussion on. While I appreciate Mr. Dean's comments looking at numbers on a sheet and calculating how many people we're caring for, that's just one thing. That's a document, piece of paper, numbers. There's a huge need out there. So of course the numbers are large. We can talk about large numbers all day in health and human services, but it's the need we need to focus on, and we need to focus on an administration that works. I would agree with Rep. Elkins. This is a step backwards. There is a system for verification. It's done by the county and DHS, not the health plans. And it seems like it is ripe for more problems and loss of care for people who are qualifying, especially if they move and change an address frequently, which many of them do. And I think we have to acknowledge the stresses a lot of this population is under, and that we have a system in place. And I think this would be problematic on a number of levels, but that's as far as I'm going to go today. Thank you.
Thank you. Representative Liebling.
Thanks, Mr. Chair. And Mr. Dean, good to see you again. I know you've been at this for this very thing for quite some time. And I have to say, I don't think you're wrong in what you're trying to do here. I think as members here have said, I think the execution in this particular bill is not workable, but I really raised my hand to mention something related to this. I think we can all agree that we don't want to be using our precious medical assistance funds for either for people who are not eligible, or importantly, spending it on not getting health care for people. And so, again, when we're talking about this, paying a capitated rate to insurance companies, essentially, and then hoping that the numbers are right and that we're actually buying care with that, I just want to remind everybody that when we pay that rate for somebody, even if they're perfectly eligible, they may not get a tiny bit of health care in that year. And so I had this problem during the pandemic when we were keeping everybody on so as not to drop anybody who needed care. The problem is we pay that rate and somebody can get zero care or zero dental care, and we're going to talk about that some more, and we are still paying for it because we're paying that capitated rate. So my suggestion, as you've heard me make many, many times, is let's get away from that PMAP system. Let's drop the middlemen in our system and go to a system where we just pay for care. Now, there could still be fraud. I know it doesn't, nothing fixes everything 100%, but we could really save a lot of money in our system if we actually pay for care instead of paying insurance companies a capitated rate and hoping that they actually use it to buy care for members. Thank you.
Thank you, Representative Liebling. Representative Bahner.
Thank you. I'll try to be brief here. I also love the intent of this bill. I will be very upfront. I think the idea of verification is an admirable one, wanting to make sure that our dollars go to the right place, that we get the right return on investment. For every individual or dollar that goes to waste, that's care that could have gone to somebody who really needs it. So I appreciate that. I do have concerns that this solution might have some real challenges with the processing of paper forms. We know staffing is a real issue within agencies, and it always has been. But more importantly, I like some of the elements of this bill and was excited by that. But as a technologist, I can tell you, I feel like there's very likely some more elegant ways to get to this solution and do the same thing in an electronic way. that does not depend on paper. And I certainly would be happy to be part of that group who has the conversation about how to make that possible. But I just don't know that this particular delivery method is the way to do it. But I like where we're going with it, and I would be happy to participate.
Thank you, Representative Bahner and Representative Reier.
Thank you, Chair Nadeau, Chair Bahner. My questions are about the impact of the financial impact of doing this. As I hear it, there will be processing and processes required on both the health plan and the county side. There'll be printing and postage of a great number of documents. So I would like to know if you've calculated how much the increased administrative costs will be and how that will be covered, because I imagine that would be either, it would be taxpayer dollars one way or another. So I'm interested in more granular information.
Chair Bahner.
Yeah, good question. I'm going to turn that to my testifier, Representative Dean.
Thank you, Representative Bahner and Mr. Chair. I just point out that this will ask the MCOs to do stuff that they're currently not doing, which will cost money, and certainly understand that is the case. Also, just would encourage you to just look at some of the numbers of the costs of not doing this. 2016, the legislative auditor estimated that 80,000 Minnesotans were signed up for plans that they did not qualify for. That was a cost, the cost attributed to that was $200 million to the state over a 5-month period. 2019, the state was hit with $225 million in fines flagged to the state for basically the same thing for folks who were signed up for programs that they did not qualify for or that were improper payments. I think the terms waste, fraud, and abuse sometimes flow together and they lose their meaning. I like to use the term improper payments because that's really what is at stake. Did that money supposed to go out? Was the money supposed to go out or not? And that, and if it did go out and it wasn't supposed to, where could that have gone? So those are the kinds of numbers that you're looking at are in the hundreds of millions of dollars that I believe are going out. And I think that the statistics and with MMB has shown that in the past. So I think that is going to be something that this committee will have to look at moving forward. So no question, the MCOs are going to say, hey, this is not our job. I get that. I understand it. We don't do determination, but we should have a person with an address who says they want Medicaid in order to give them a check. Representative Liebling, I kind of understand that. I look at it from the Lifetime Fitness paradigm, which is Lifetime Fitness loves me because I give them money every month, and I've never ever used a piece of their equipment, but I intend to. So they do benefit from that. However, we need to make sure that we are covering folks that live here and qualify and are still alive.
Thank you, Mr. Dean. Quick follow-up.
Thank you, Mr. Chair. Thank you, Mr. Dean, for your response. Have you calculated how much the increased administrative cost would be? And it would not be just the health plans, and I assume it would be translated over into higher premiums, especially in the commercial sector, which is a great concern for many of us. And also, there will be costs to the counties, so I'm wondering if that's been calculated. Thank you.
Thank you, Representative Reier. Representative Chair Bahner, would you close on your bill?
Yes, so right now, determination is based on several assumptions. This bill gives a second set of eyes, and we'll be working on this and moving forward with some good suggestions that we had today. Thank you, Chair.
Thank you, Chair Bahner. The chair lays over House File 2604 for possible inclusion in an omnibus bill. And we are moving on quickly to House File 2955. And I will move House File 2955 before the committee with the intent to lay the bill over. Chair Bahner, please introduce your bill.
Yeah, thank you. This is county purchasing for our Medicaid, Medicare individuals. This bill has been worked on for a number of years, I think 2 years, with the agencies, DHS and so forth. So Section 1, what it does, it deletes language that is in the existing CBP law. And so we've known that CPA plans have operated successfully in rural Minnesota for 45 years. And so this builds on it. If we look at Section 2, it gives updates definitions. Section 2, subsection 2, just reestablish the goals. It describes the goals of the program. I'm a big believer. If you don't have a target, you'll never hit it. Section 2, subsection 3 talks about who can participate. Subsection 4 gives oversight and regulations. We just had a bill on oversight. It's important that there are checks and balances. Subsection 6 talks about benefits and services. Subsection 7 talks about payments. Subsection 8 talks about qualifying measures. On that, DHS and the counties have worked to set those measures and so forth. So there's been a lot of work on this bill. Subsection 9 talks about data and better integration of data, because we know if we are able to have better sets of data, that we're able to do a better job for the taxpayers. Section 3 talks about requests for federal waiver, and with that, that is a summary of what that bill, there's a lot of work that's been put onto that. So with that, I'm going to turn it to our testifiers. Thank you, Vice Chair Nadeau.
Thank you, Chair Backer. Please introduce yourself and start your testimony.
Chair Nadeau and Chair Backer and committee members, thank you for the opportunity to testify in support of CARMA legislation. I'm Commissioner Brad Anderson from Goodhue County, serving my 11th year and a member of the South Country Health Alliance Joint Powers Board. County-run health plans are currently implemented in 32 counties. That represents 160 elected county commissioners and hundreds of county frontline staff supporting the county model of delivering public health plans. That work is done with a goal of integrating the health plan with related social needs for our kids, seniors, and those citizens with complex and complicated health challenges to address the whole person's needs. These programs work to serve the citizens who are most in need of public assistance, and as commissioners, we are passionate at work. I was here last year advocating for the continued work of DHS and AMC and the county-run health plans to pass bipartisan legislation directing the creation of the CARMA model and the legislation in House File 2955. We collectively did the work, and the product is this legislation. We came at the work with a goal to develop a plan that addresses the challenges in delivering services in rural Minnesota. This bill is built on delivering outcomes we all support and reducing barriers to achieve those outcomes through integration of the health plan and delivering related programs to address the needs of these citizens. House File 2599 was developed with DHS and counties in alignment, knowing that collectively we can do better. This approach addressed rural challenges, a whole community approach, integration of services, local decisions, and local oversight. Delivery of services presents unique challenges in rural areas, and counties have developed models that directly address that from the local perspective. Counties know the community resources and are leveraging those resources at the local level every day, working alongside with the county-operated health plans to ensure the best possible outcomes for our residents. We integrate public health, human services, and the county-run health plan to wrap services around our citizens with person-centered care. It is elected officials, local county employees, and county-run health plans that collectively are involved in the health plan work.
Please wrap it up.
We do not usually get involved from the beginning of a program design and drafting legislation to accomplish mutual goals. This process, developing this legislation, has been collaborative, rewarding, and consensus building between all parties involved. This has led to an outcome that we use as a model to reimagine, rework programs to efficiently use our limited resources to serve the needs of citizens in our counties. Counties are ready to continue this work. I commend the DHS, the staff at DHS and AMC for engaging in this collaborative work to develop the CARMA model. It will serve our citizens well. Thank you for the opportunity to speak to support this legislation.
Thank you very much. Please introduce yourself and start your testimony.
Mr. Chair, members of the committee, my name is Matt Freeman. I'm testifying on behalf of the Association of Minnesota Counties, where I serve as Human Service Policy Analyst. Association of Minnesota Counties enthusiastically supports the County-administered Rural Medical Assistance, or CARMA, model legislation. This legislation is a result of collaboration between DHS, counties, and county-based purchasing plans over the last several years. It builds on the successive CBPs of over the last 40 years while bringing innovation to the county-based approach to delivering public programs to our greater Minnesota communities. CARMA features greater integration of healthcare, public health, and social services to address health-related social needs, accounts for the smaller number of medical assistance enrollees and providers in rural counties, and seeks to streamline systems to better serve enrollees and promotes greater accountability for outcomes. We ask for your support for this legislation.
Thank you. And is Chelsea coming up? Okay, good. Please state your name again and start your testimony.
Hi, my name is Chelsea Olson with the Minnesota Council of Health Plans. Thank you for the opportunity to testify today with our concerns on House File 2955. As the council has testified in the past on the CARMA model, as well as other bills impacting the availability of managed care, we firmly believe that level playing field competition is important to enhance services, and consumer choice is especially important when it comes to accessing the healthcare services that you need. As the legislature considers the CARMA model, we are concerned enrollee choice and the benefits of market competition would be eliminated for Minnesotans and counties that choose the CARMA model. We firmly believe Minnesotans are best served when all health plans, including the county-based plans, compete on an even playing field with their products and services, and where Minnesotans can make their own choices accordingly. This bill instead proposes to eliminate MCO managed care as offered by our nonprofit members in any county choosing CARMA. This eliminates the benefit of competitive bidding and natural competition to enhance services. Minnesotans would also no longer have any choice in which plan they prefer. Currently, that's often 2 or 3 choices, and instead they would face a mandated one-size-fits-all plan as decided by their county government. It's important to note that CARMA mirrors previous attempts to limit competition via sole source that has resulted in multiple rounds of litigation between county-based plans and the state. As such, if advanced, this may generate even more lawsuits, and instead we encourage the committee to preserve choice for Minnesotans and the benefits of competitive bidding for the state. Finally, these examples and others are likely to be explored in the pending DHS report that was commissioned by the legislature in 2024. We strongly encourage the legislature to consider the results of the reports and other factors before moving forward with this model. We appreciate the committee's time today and appreciate your consideration.
Thank you. And would DHS care to come up and comment on the drafting of this legislation? Thank you. Please state your name and start commenting.
Thank you. My name is PJ Weiner. I am a director with the Department of Justice, and I don't have any prepared comments today. I can just say that we have worked for now over 2 years on this product with the county-based purchasers, AMC, and our counties, and are supportive of the intents of the legislation, and I'm happy to answer questions that any members might have that DHS could respond to.
Thank you so much. And I knew that you guys worked so long and hard at this, so just stay up there, and we're going to go to is there any other members of the public that want to testify on this legislation? Seeing none, I'm going to close that. We'll move to members. Representative Liebling.
Thanks, Mr. Chair, and thanks, Ms. Weiner. I'm glad you came up, because my question really would be for you, and that's about getting the waivers, because this requires, it has, at the end of it, a request for federal waiver, and I just wonder if you probably, you obviously you can't predict the future, but can you say anything about the possibility of getting a waiver for this program?
Chair Backer.
Yeah, I'm going to turn that over to PJ, right? Go ahead.
Mr. Chair and Representative Liebling, I can't speak to what the likelihood of getting a waiver is. I will say that my understanding of the language, and I need to look at my colleagues here to just confirm this, but I believe has a later implementation date. Which will give us some time to understand where CMS is going with these types of proposals.
Thank you. Representative Liebling, follow up, or are you good? All right, other members? Seeing none, thank you, Chair Backer. Please close on your bill.
Thank you, members. It is so important, especially in Greater Minnesota, to give people options at work, especially local. I've seen this work in Travers, Grant, also in Stevens County, Big Stone County that I've represented in the past. And the feedback I get from the county-based purchasing has always been positive. The few times that there's been concerns, I actually will call and they get on it like white on rice. So it is a very good program, and thank you for members' support.
Thank you. The chair lays over House File 2955 for possible inclusion in the omnibus bill. We are now moving on to House File 2909.
Okay, the chair moves House File 2909 before the committee with the chair's intent to lay the bill over for possible inclusion. Representative Bahner, please introduce your bill.
Thank you, Mr. Chair. I will say first, we do have an A1.
Oh, that's right, thank you.
Yes.
You're on the committee, did you want to move that?
Yes, sir. I would like, Mr. Chair, I would like to move the A1. This is essentially a technical change to make clear that the services are performed by pharmacists and not pharmacies. So you will see on the A1, it's a pretty basic technical change, but wanted to make sure that's clear.
Okay, any questions from members on that technical change? Okay, so we did not print that. We're going to have to do an oral amendment.
Oh.
Oh, no, it's, okay, we have it. Oh, we do? Okay, cool. Thank you. Thank you,
Yes.
Vice Chair. Thank you very much. We do, folks. We have that amendment. So, okay, so all those in favor of that A1 amendment, say aye. Aye. All those opposed, say nay. The motion prevails and the A1 is adopted. Representative, to your bill.
Thank you, and thank you to Ms. Mock for getting that done quickly. So, Mr. Chair and members, the bill before you is pretty simple and straightforward. It ensures that fully credentialed, trained pharmacists and supervised pharmacy technicians who are an essential part of the care continuum may get paid by medical assistants for the services they perform for patients in the pharmacy setting. By having pharmacists and pharmacies as a partner in patient care, we provide patient access across the state, the convenience they want with the access they truly need, meeting them where they are in our community. These services include the administration of basic maintenance medications or essential services like vaccinations, health testing, and other medication management services for our patients. In the past few sessions, Minnesota led
patient care by authorizing pharmacists to prescribe, counsel and administer healthcare screenings, work with patients to quit smoking, prescribe and administer HIV prevention medications, and made it easier for women to obtain contraceptives. But often they're unable to be paid to deliver these services outside of the clinic setting, leaving pharmacies in a bind. Last session, we passed coverage for services, this very bill, for the private payers, but stopped short of coverage for all insurance types, notably MA. This bill would close that gap. Our local pharmacies form the cornerstone of our communities, with many patients seeing their pharmacist more frequently than their healthcare provider, performing a significant level of trust. Ultimately, providing these services means lower costs for patients and payers, and most importantly, delivering better patient care outcomes for patients in rural and urban settings. The bill allows fully credentialed pharmacists and pharmacy technicians to provide the essential services patients need in a setting they know and trust. It makes good common sense that they should be paid for the services they provide to meet the needs of our communities. This bill will ensure that local and independent pharmacies in greater Minnesota and our urban centers continue to provide these services, ensuring their survival and their ability to thrive in our community. And with that, I will pass it to my testifier.
Yes, thank you. Thank you, Representative. Dr. Westberg, please state your name, and we ask to keep it to 2 minutes, please.
Got it. Thank you. Well, good afternoon, Chair and committee members. My name is Dr. Sarah Westberg. I'm a pharmacist, a professor, and Associate Dean of Professional Affairs at the University of Minnesota College of Pharmacy. However, today I'm not representing my employer of the University of Minnesota. Today I'm here representing the Minnesota Pharmacy Alliance in support of Representative Bahner's House File 2909, coverage for health services performed by a pharmacist under their scope of practice. The Minnesota Pharmacy Alliance is made up of representatives from the College of Pharmacy, the Minnesota Health System Pharmacists, and Minnesota Pharmacy Association. We represent pharmacists, pharmacy technicians, and future pharmacists in all practice settings across the state. Representative Bahner's legislation aims to ensure that pharmacists are compensated for providing healthcare services to Medicaid and MinCare patients for improvement in health outcomes. Pharmacists are highly trained experts, trained with a professional doctor of pharmacy degree known as a PharmD. We have a deep medication expertise that is unique within the healthcare team. This bill advocates for fair and adequate MA coverage for pharmacist services. Last year, as Representative Bahner spoke to, legislation was passed to enact consensus legislation to provide coverage for pharmacist services for commercially insured Minnesotans. This legislation aims to provide that same coverage for MA patients. Medicaid patients rely on pharmacists for accessible, cost-effective healthcare services, and this legislation ensures that Minnesota pharmacists can offer a full range of healthcare services under their scope of practice. What exactly are the services we're talking about? This expanded coverage includes targeted services provided by pharmacists, such as chronic disease management to improve outcomes related to diabetes, hypertension, high cholesterol, and others. We offer medication and vaccine administration, health screenings, test and treat programs, prescribing certain preventative treatments. This proposal focuses on expanding access to essential healthcare services for Minnesota Medicaid patients. We urge you to support Representative Bahner's House File 2909. Without coverage, providing these services becomes unsustainable, limiting access to quality healthcare. So thank you for your support, and I'm happy to answer any questions.
Thank you. We turn to the public. Is there anyone else that would like to testify on House File 2909? Okay, seeing none. Members' discussion. Oh, okay, Representative Van Binsberger. We'll get it. Thank you.
Thank you, Mr. Chair. I'm just curious about overall cost. I know, do you have any, I'm sure there hasn't been a fiscal note yet, but do you have just kind of a range, a thought?
Representative Bahner.
Thank you. I believe it was 4.5 million last year was the fiscal note. We do have requested a fiscal note this year. We do believe that there may be some revisions to that estimate, actually, based on some clarified pieces in the bill that might actually bring that cost down, but we will not know, unfortunately, until we get the fiscal note back from DHS, but it has been requested.
Follow-up, Representative Van Binsbergen.
No, thank you.
Okay, very good. Representative Chair Liebling, go ahead.
Thank you, Mr. Chair, and thank you, Representative Bahner. And I know that in the last couple of years, we expanded, as you were saying, for the commercial market, and we expanded payment, but we also expanded the ability of pharmacists to do certain things. And I just wondered if, and of course, you know, we all know that this is critically important because pharmacies are really struggling, and that's a lot of what's behind this, right? We need to make sure that there is a network of pharmacies throughout the state, and that's really at risk. But I'm just wondering if there's, if the testifier can just give any sort of update, knowing, you know, notwithstanding that you're asking for this, but are pharmacists actually doing a lot more of the things that we authorized in the last couple of years? I just wonder if you could say a word about that, not taking a lot of time, because I know the chair's in a hurry.
Representative Bahner.
Or actually, I'll pass that to my testifier, Dr. Westberg.
All right, Chair and members, thank you for that question, Chair Liebling. Yes, pharmacists are absolutely doing more and more in community pharmacies as well as health system pharmacies every day. A great example that I think is tangible to many of you is test and treat in community pharmacies, the ability to go in, get a test for flu. They work under a collaborative practice agreement, can prescribe of antiviral if that's appropriate, same for strep testing. That's the type of service that isn't covered well currently that this bill would allow for. Hormonal contraceptive prescribing is another example. Many pharmacies have implemented programs to be able to prescribe hormonal contraception. And again, that service isn't always covered. So as well as smoking cessation and others. So it is happening. It's happening in, you know, not the volume we'd like because of the limitations on the sustainability based on the cost.
Thank you.
Okay, thank you. Other questions, members? Representative Bahner, close.
Thank you, Mr. Chair. As said by Dr. Westberg, I think there is a real desire for pharmacies to perform these services, but knowing they cannot get paid is a bit prohibitive. And I know that we like to talk about balance in this committee. We did do this for those commercial payers last year. This is an attempt to try and even the playing field. We certainly understand and appreciate there will be budget limitations this year, and we'll have to see that fiscal note. But I do think this will add real value for patients in our communities and for pharmacies and pharmacists. So I would thank you for your support.
Okay, thank you. The chair lays over House File 2909 for possible inclusion in our omnibus bill. Next, the chair moves House File 2242, Representative Nadeau, before the committee with the chair's intent to lay over the bill for possible inclusion. I understand Vice Chair Representative Nadeau has a DE amendment.
I would love to move my own DE amendment, Mr. Chair. I tried doing it in Human Services earlier this year, and it didn't work.
Well, we may give you some more grace here, maybe. Did you want to speak briefly on what the DE does there, Vice Chair Nadeau?
Yes, it is the major technical changes of the bill that develop the payment process that allows a single benefit administrator to exist in Minnesota.
Okay. Any questions on the DE? Okay, seeing none. All those in favor say aye. Aye. All those opposed say nay. The motion prevails and the amendment is adopted. Nadeau, introduce your bill as amended.
Thank you, Chair Backer, and thank you, Chair Bierman, as well for hearing this bill. This is the House File 2242 is the Medical Assistant Single PBM Prescription Drug Management Model Authorizing Language. I talk a lot about our healthcare partners in this committee, and sometimes we don't think about our pharmacists. We think about our doctor, our nurse, but not necessarily our pharmacists. Like any doctor, nurse, dentist, mental health professional, or other provider, pharmacists cannot provide services and certainly not medications for less than the cost if we're going to expect them to stay in business. Pharmacies, as we've heard all session, are closing across Minnesota at an alarming rate, and patient access to critical medication and pharmacy health services is at a tipping point for hundreds of communities, especially in greater Minnesota. House File 2242, as amended, creates the single pharmaceutical benefit management plan model, essentially acting as a pharmacy benefits administrator, intending to save significant dollars, increase pharmacy cost reimbursements by having another partner that's focused on the 80 to 85% of MA patient medication claims that are currently reimbursed through a state MA contracted management care organizations and their PBMs. This bill addresses the RFP, specifically this bill addresses the RFP process. It identifies the acquisition cost components that drive these reimbursement, and it addresses the payment rates and how we will choose a single PBA. Earlier this session, this committee heard and laid over Representative Bahner's House File 1100, and that's a Lifeline program that's targeted to pharmacies in Minnesota. This targeted pharmacy Lifeline program is similar to programs that are done in other states across the nation. It's a short-term bridge that will hopefully help pharmacies until we get this bill crafted and enacted and working. Minnesota's not alone in this challenge. Other states have been frustrated with rising pharmacy costs, and they've decided to carve out retail pharmacy benefits management from their contracts with Medicaid. Managed care organizations, direct fee-for-service carve-out management models have their critics, I'm one, and have an impact on the covered entities' 340B claims savings, which is, that's my problem. However, this bill, I believe, is a middle ground approach for state Medicaid programs, a single PBM, or really a PBA, that drug spend management model, and it was first tested in Kentucky. It's gaining steam in 3 other states, Ohio, Louisiana, Mississippi. They followed in Kentucky's footsteps after the state implemented their programs in 2021. With this approach, Medicaid MCOs still get paid for providing pharmacy benefits, but must contract with a single PBM and use a preferred drug list that's selected by the state. The single PBM model also has constraints on the management of the drug benefit and essentially acts as a PBA that prohibits the use of spread pricing, clawbacks, below-cost pharmacy reimbursement, formula fees, and reduces the amount paid per claim to manage the adjudication of those claims. Virginia passed an SPBM drug benefit management model early in February of 2025, will be implemented in 2026. Kentucky model switched to a transparent model with a single PBM. By 2023, the state saved nearly $283 million and is projected to save $200 million per year. Ohio, Medicaid implemented a transparent payment model where the Medicaid contracts with a single PBM set of pharmacy reimbursement rates under a drug cost plus model. The net savings have exceeded $100 million each year. I'm not going to go down the list of states. I want to simply state that every state that's implemented one of these models has stabilized pharmacy cost reimbursements. It's found differing levels of savings in this benefit set. Another reason to change the Minnesota medical assistance drug benefit management model to a single as opposed to fee-for-service direct carve-out model is that it, as I mentioned before, it protects 340B discounts that manufacturers must give to covered entities. As demonstrated by the results of the Minnesota Covered Entity Study reported late last year, 340B savings is clearly a critical revenue stream to health systems that serve patients across Minnesota. I hope that by reforming and streamlining the drug benefit management model for Minnesota MA, the state will save money. It'll go a long way in making sure that medical assistance patients and all Minnesotans can access pharmacies in their community by making the MA pharmacy benefit management more efficient by reimbursing community pharmacies at a sustainable rate. And with that, I would like to invite my testifiers to come up and tell the real story and just remind the committee that there's a lot of very smart people in this room on the edges that can answer a lot of the technical questions, and this has been a heavy lift on them more than anyone, but a lot of people have come together to try to make this work. So with that, where are my testifiers?
Okay, go ahead. Come on down. Please state your name And then 2 minutes, please.
Thank you, Mr. Chair and members of the committee. My name is Tricia Hines.
Can you move the mic just a tad bit closer, please?
Again, my name is Tricia Hines. I'm a fourth-generation independent community pharmacist. I own and operate Newport Drug, which has been serving the community in and around Newport for 3 generations. Before that, my great-grandfather had a store on St. Paul's East Side. I'm here today in support of House File 2242. Pharmacies across the state are in crisis. At risk is our ability to care for our patients and serve our communities because of the current reimbursement model in retail pharmacy. House File 2242 would provide a solution that we desperately need. Independent pharmacies are often paid below our costs based on essentially non-negotiable contracts with the PBMs. In Minnesota, the Medicaid program, using a managed care model and PBMs, to care for about 85% of Medicaid patients. About 60 or 65% of those prescriptions that I fill are reimbursed below my cost for doing business. Included in that, 60 to 65% of below operational cost prescriptions are many prescriptions that are even below my cost of goods. Obviously, this isn't sustainable. I can't continue to operate when I'm reimbursed below my cost of doing business, or worse yet, below my cost of goods. Just this morning, I filled 1 blood thinner prescription for 1 Medicaid patient. That put me about $400 below my acquisition cost for the year. 1 medication, 1 patient. You can see how this quickly adds up, especially for patients with very complicated disease states and long lists of medications. Independent pharmacies like mine build long-standing relationships with our patients and are a resource for people as they try to navigate our complex healthcare system. We're often the only easily accessible healthcare option for some of our most vulnerable patients.
If you could wrap it up, please.
House File 2242 would allow the state to ensure pharmacies are reimbursed fairly, thus allowing pharmacies serving Medicaid patients to be able to continue to do so and minimize pharmacy deserts. Pharmacies need help now. Please help keep pharmacies open and maintain access to patient care by supporting this. Thank you, and I welcome any questions.
Go ahead, state your name and 2 minutes, please.
Hello. Thank you, Mr. Chair and members of the committee. My name is Andrew Russell. I'm co-owner of Elko New Market Family Pharmacy in Elko New Market, Minnesota. I'm here today representing Minnesota independent pharmacists in support of House File 2242. On March 21st of this year, pharmacist Phil Hummerding was hard at work at his store in Rochester when he received a prescription for an EpiPen, a potentially life-saving product used in the event of an emergency allergic reaction. The price his pharmacy would have had to pay to acquire this specific generic EpiPen required for this patient was $285.60. However, the insurance claim processed by a middleman company, the PBM, showed his pharmacy would be paid only $48.94 for that prescription, and he would be paid $0 for the service of dispensing the prescription. The pharmacy would lose $236 on this one transaction. This particular patient was a Minnesota Medicaid recipient with no ability to pay for the prescription without using insurance. Thus, Phil was left with a very difficult choice: turn the patient away or lose the equivalent of several hours of his staff's wages simply by doing his job. So what's going on here? Minnesota uses several managed care organizations to cover about 85% of enrolled Medicaid patients and contract with for-profit PBMs. These PBMs have total control over how pharmacies are paid to fill prescriptions. PBMs use consolidated market power to force take it or leave it contract terms on pharmacies, including maximum allowable cost lists. These lists is how this particular MCO, via its PBM, decided to pay Hunt Drug in Rochester $48.94 for a drug product that cost $285.60, again with a $0 dispensing fee for his service. The math just does not work. Patient access starts with an open pharmacy. Unfortunately, as more and more pharmacies are faced with filling prescriptions at a loss, they are closing at an alarming rate. There's a substantial need for local community pharmacies throughout Minnesota. In fact, we've been approached by several cities at my pharmacy in the last few years asking if we'd be able to open a pharmacy like ours in their community. Most recently, the city of Lonsdale, who lost their only pharmacy in 2018. Unfortunately, the answer has had to be no each time, as the way we are forced to do business virtually guarantees it will not be successful.
If you could wrap that up, please.
Certainly. This is bipartisan legislation that will save the state a considerable amount of money. It will establish an accurate and transparent drug pricing index, reduce duplicative administration spending, stop abusive tactics used by PBMs, and will help level the playing field for Minnesota pharmacies. Patient access starts with an open pharmacy. I urge you to support this bill to preserve pharmacy access for Minnesota's most vulnerable patient populations for years to come. Thank you.
Okay, and we have one more testifier. Please state your name and the 2-minute warning.
Thank you, Chair, Co-Chair Bierman, Chair Backer, members. My name is Buck Humphrey. I am the representative of the Minnesota Pharmacy Alliance. Dr. Westberg earlier spoke to you about who that is. I am here to support Representative Nadeau's HF 2242, that authorizes a single PBM, really a pharmacy benefits administrator, for the MA Medical Assistance Drug Benefit Management. I want to echo what you just heard today and put a few numbers around that. 61% of all Minnesota independent pharmacies are gone in the last 10 years. 39% of all chain drugstores and pharmacies are gone in the last 10 years. And now 17%, you have the MDH map in your packet, 17% of all zip codes in Minnesota don't have access to pharmacies. That's not just in rural Minnesota, but it is prevalent there. It's also in North Minneapolis. It's also along the University corridor here in St. Paul. And where there used to be 3 Hmong-speaking pharmacists who own pharmacies, there's now 1. This is impacting every community across Minnesota. The common denominator for all community pharmacies that have closed or about to close, whether it be independent or chain, is unsustainable reimbursement, as you've heard from our MCO PBMs that are contracted by the state of Minnesota to serve just under 1 million Minnesotans as their insurer. Today, we are here to support Representative Nadeau's bill that will reimburse pharmacies at their actual acquisition cost and a dispensing fee that is the mean, so 49% above, 49% above, of what they cost to dispense that medication to an MA-insured patient. It also will save the state money, and it will not impact the 340B savings revenue. Minnesota pharmacies and our patients need a long-term solution, and this bill is it. As with the other states, such as Ohio and Kentucky and the others you heard about that transitioned over the past 3 or 4 years, they have seen considerable savings, efficiencies, and much less administrative burden. I urge you to enact this legislation. Thank you. I'd be happy to answer any questions, Mr. Chair.
Okay, is there any other public testifier? Okay, seeing none, we're going to take about 5 minutes of questions on this because this will be laid over. So I do turn this over to member discussion. Chair Liebling. Oh, I'm sorry. We did have Representative Elkins first. He did do it, then we'll go to you. Go ahead, Representative Elkins.
Thank you, Mr. Chair. I'm trying to understand the mechanism by which this doesn't take away the safety net hospital's so-called 340B revenues. Maybe the author or Mr. Humphrey can explain what the mechanism is.
Vice Chair Nadeau. Go ahead.
Yep. Chair Backer, members. So the number one concept is you cannot double dip. You cannot take a state rebate on a brand name drug and 340B discount pricing from the manufacturer. That would be like double dipping. So unlike the fee-for-service carve-out where 340B pricing, ceiling pricing is not available and would be impacted, this is a hybrid that Kentucky and Ohio really experimented and came up with, Governor DeWine in Ohio. And what it says is you can take rebates on those drugs that are being dispensed that are not 340B entity, and then you cannot take that on 340B entity. So that does not impact the savings. I don't know, I hope I'm clear. So you got, in the fee-for-service model over here, you can take rebates. in the 340B claims, and if you look at the governor's proposal, it's about 500,000 claims a year, or about 30%. Those are 340B pricing, and so this would not impact that.
Follow-up.
Yeah, so the distinction is based on the provider level. If the provider is a safety net hospital eligible to buy at the 340B rates, they're not included in this proposal. Am I getting that right?
No.
Go ahead.
Mr. Chair.
Yeah, go ahead,
Sorry.
Mr. Humphrey.
No, they're included. The single pharmacy benefit administrator, really a transaction administrator, will also manage those transactions, but on a claim-by-claim basis. If it's a 340B claim, the state cannot take rebates.
Okay, we're going to go to Chair Liebling. Go ahead, please, with your question.
Well, thanks, Mr. Chair, and I'm sorry we only have a few minutes, because this, honestly, this deserves a lot more discussion. And thank you, Representative Nadeau, for, for thinking about this issue, and certainly as a way to help pharmacies. This is good, because we need to get control over the PBMs. There's no question about that. I, though, think this is a little bit problematic doing it this way. And I just have a few questions about it. The 340B issue, this proposal, first of all, I don't see, it's been mentioned a few times that there are savings to the state. I don't see anything like a fiscal note, like what those savings would be, but I'm just not understanding where would the savings come from. If we're still paying the MCOs to manage a pharmacy benefit, but then we're having one PBM to do it for the state. I don't see what we're paying the MCOs for, and I don't see where these savings would be coming from. Can you clear that up for me?
I can clear up the first part.
Go ahead, Vice Chair Nadeau.
Sorry, Chair Backer.
Okay.
I can clear up the first part. We have requested a fiscal note. We don't know. Every state's been a little bit different, but we don't know exactly the cost to set this up yet. We will have it before before this thing moves through. The second part of that is
Representative Nadeau, we do have someone from DHS, if they could come up and help with that question.
Yes, he's right here.
Okay, well, great. We didn't see him behind the pillar, but you did.
This is the guy you guys want to talk to.
Okay, state your name and help with that question, please.
For the record, my name's Chad Hope. I'm the pharmacy director at DHS. The language here was structured after the Ohio model, where the state of Ohio implemented what's called an actual acquisition cost pricing type, where the pharmacies have to actually submit their purchase invoices for all the drugs that they purchase, and the state, through a contractor, comes up with what the statewide acquisition cost is based on purchase invoices. Those purchase invoices are then used, the aggregate purchase invoice is used to reimburse the drug cost of the claim. And at least in the state of Ohio, when we connected with them, they reported that they saved about $400 million annually based on that new pricing type. So the language here incorporates a Minnesota version where Minnesota pharmacies would have to submit their purchase invoices, and then that purchase invoice type would be used to reimburse the drug costs. The offset to that would be the dispensing fees would increase to the fee-for-service dispensing fee. As far as the managed care plans go, this would still be under a managed care-like authority that the benefit's being delivered in. That's why the 340B revenue to the 340B covered entities is still generated on the MCO volume, is the PBM is essentially paying like the PBMs are today for the 340B covered entities, whereas the fee-for-service program is not rolled into this single administrator. So the fee-for-service program will still continue to pay at the lower ceiling price estimate.
Okay, follow up?
Yeah, thanks, Mr. Chair, and thanks for that. Well, yeah. So I guess I just want to make a couple comments then. It sounds from what Mr. Hope said, like in Minnesota, we might not actually save anything as a state, because it sounded like from the testimony that we're not paying the acquisition costs. So if we actually go to paying the acquisition costs, that's more money, not less. And of course, there's paying the dispensing fee, which I very much think we should be paying and they should be getting. I mean, don't get me wrong, they need this money and they should be getting it. But for the state, it sounds like it's really going to cost more, not less. The other thing I just want to make sure everybody understands, when we're talking about this money, this 340B money, we did the first report on 340B, and what I learned from that report is that there's a lot less money actually going through our Medicaid program to these covered entities than I had thought. Initially, it was like, oh my gosh, don't take this away from us, we will just crash and burn. Well, it's really a lot, most of it's coming through the commercial side, which I don't fully understand, but it's not coming mostly from Medicaid. But I do want members to understand that what is coming through Medicaid, we are paying a hidden subsidy. We are subsidizing providers through our Medicaid funds without fully knowing it. And that's because we are paying inflated prices for drugs. We are paying for the drugs at market price instead of at the discount price that the state would get. And that's why the governor's proposal saves the state a bunch of money without, and also does good things for the pharmacists, because we would be paying them at the dispensing rate, and we could also presumably pay them at the acquisition cost. We could adjust those things, I hope, if we did the governor's carve-out. And we would be saving a bunch of money and doing all these other good things, too. The only, and I get that some organizations would lose this hidden subsidy. But this year, I haven't really heard from any of them. I haven't heard a thing. And as my understanding, too, is the 340B hidden subsidy is only on outpatient. That's and I don't know, Mr. Hope, if I'm completely off base here. He's nodding yes, so I'm not way off base. They were only talking about outpatient prescriptions. That's the thing that we pretty much did capture in the first report. We didn't really capture all the inpatient, but that's not involved here. So in other words, just to kind of wrap this up, I think we would do a whole lot better with the real carve-out than with this thing that just keeps the MCOs involved for basically no benefit or for very little benefit and doesn't probably save us money. And this year, we really need to be saving money where we can without cutting benefits for patients. So thank you.
Okay, members, I would ask Representative Hewitt if you could take your question offline, because we want to get to Representative Bierman's bill, which is the governor's bill. So with that, I'm going to have Representative Nadeau close on this bill.
Thank you, Chair Backer and members. And this is it's a complicated bill, and reach out to all of us if you have questions about it. But this bill, like I say in my opening comments, every state that has implemented this has found some significant level of savings. And it's also helped stabilize the cost reimbursements to our independent pharmacies. So that's really the goal of this thing. Thank you again for hearing my bill.
Okay, the chair lays over House File 2242 as amended for possible inclusion in the omnibus bill. Right before Representative Bierman's bill, we are going to take up Representative Gillman's bill. We're going to keep that to 5 minutes. So that's House File 1883. Representative Gillman, would you like to move your bill before the committee?
Would love that. Thank you, Chair.
Okay, Representative Gillman, I believe you have an A1 author amendment. Members, could you, no, A2, yep. Let me do that again. I believe you have an A2-1 author's amendment. Members, is there any discussion to that amendment? Okay, seeing none. Representative Gillman moves to adopt the A2-1 amendment. All those in favor say aye. Aye. All those opposed say nay. The motion prevails and the A2-1 amendment is adopted. Representative Gilmore, introduce your bill. You got 5 minutes.
I like that name. Mr. Chair and members of the committee, thank you so much for the opportunity to present House File 1883, a bill that warrants all of your consideration today. So today's surgical instruments are highly complex and ever-changing. They involve many tiny channels and crevices that can hide debris. Central service technicians perform their jobs at times with little to no training, and yet they are required to know 37,000 different surgical instruments. Who are central service technicians? Central service technicians are responsible for ensuring that equipment and instruments used during surgical procedures are properly disassembled, cleaned, inspected, sterilized, and then reassembled prior to patient use. According to the Bureau of Labor Statistics, in 2022, there are 1,300 or so service technicians in Minnesota. So why are they so important? Central service technicians perform tasks that are integral to patient safety, yet their profession is unregulated. A person could be hired off the street to sterilize these surgical instruments, and then those instruments are used to perform procedures on patients. Minnesota has had several health issues related to outbreaks caused by dirty surgical instruments due to improper cleaning. One medical center notified 100 patients exposed to unsterile instruments. Another medical center notified patients from 4 surgeries that unsterile surgical instruments were used during their procedures. The ACA established the Hospital Acquired Condition Reduction Program. And I'm just going to speed this along and just go right to my testifiers because I could go on and on. It's a very complex thing that I'll just introduce my testifiers. We'll get this rolling.
Okay, please state your name, and we ask you to keep your testimony down to 1.5 minutes.
My name is Josephine Kalachi, and I am Director of Government Affairs for the Healthcare Sterile Processing Association. We're here today to support House File 1883, which would require new central service technicians to be certified and maintain annual continuing education credits. Currently, there are 6 states that require this certification, very similar to the legislation before you. Those 6 states are New York, New Jersey, Delaware, Connecticut, Pennsylvania, and Tennessee, with pending legislation right now in Florida. I know that you received a letter from the Ambulatory Surgery Center Association, and I just want to address a part of that letter. They mentioned English as a second language for possible doing that with continuing education credits. I can tell you that that is the first time we have received that question, and at our next board meeting for the association, I'm going to mention this to see if this is something that we can add to help with the continuing education credits moving forward. And with that, I'm happy to turn my testimony over to Matt.
Okay, please state your name and ask you to keep it to 1.5 minutes, please.
Good afternoon. My name is Matthew Thel, and I am a program manager for high-level disinfection and sterilization at a healthcare organization in Minnesota. I also serve as the president of the Minnesota Sterile Processing Association, and today I'm here to support the House File 1883. Just to reiterate a little bit of the complexity of the work that central sterile technicians do. Given an example, they'll process thousands, hundreds of instruments during their work. And each of these devices come with a manufacturer's instructions for use that need to be followed meticulously. For example, a flexible endoscope that's processed in a healthcare facility can have up to 118 cleaning steps associated with that. In addition to that, a hospital that has 15 operating rooms can perform on average 13,000 cases per year. This essentially translates to 1.2 million individual instruments that are touched by these central service technicians every single year. Given the complexity and importance of their work in infection prevention, we support the central service technicians get the certification to enhance their role in providing safe patient care. Thank you.
Thank you so much. Anybody from the public that would like to comment on this bill? Okay, seeing none, open up to members' discussion. Who do we have? Bierman. Representative Bierman, did you have a question? Okay, thank you.
Thank you, Mr. Chair. Thank you, Rep. Gillman, for bringing the bill forward. I had the opportunity to go tour over at the University of Minnesota, the central service cleaning area that they use for this, and it's an immense operation. And it's a behind-the-scenes kind of process that you don't think about when we're doing the rest of healthcare. And the importance of it was really brought home to me. So appreciate you bringing the bill forward. And this is something that we, all of us need. We just don't, some of us just don't know about it until you really get behind the scenes and see all the work and the amount of cleaning processes and the professionals that do it. So thanks for the bill.
Representative Zalisicard.
Thank you, Chair, and thank you, Representative Gillman, for bringing this bill. As someone who nearly died twice from sepsis infections, I think this is a bill that it's shocking to me we haven't done it sooner, actually. I don't know if members know this, but sepsis in hospitals kills more people than opioid deaths or prostate and breast cancer together, which was shocking to me to learn when I almost died twice of sepsis. And bacterial infections in a setting of a hospital or surgical center are high risk anyway for all of us. And so to have cleaning protocols and infection control protocols at that level, I think this is really an important bill, and I appreciate that you're doing it.
Representative Francis. Franson, please quick.
Thank you, Mr. Chair. Representative Keeler, I lied. I'm talking on two bills today, so I know. To the bill author, thank you. I did not realize until recently how prevalent sepsis is. My best friend had surgery on her abdomen area and ended up in the hospital for a few days because of sepsis, and she's still fighting that. And another constituent of mine had either hip or knee surgery, I can't remember, and back in to get it replaced because of sepsis. So thank you. I honestly had no idea that it was so prevalent and kind of laxy-daisy on the sterilization. So
Close on your bill, Representative Gillman.
I just want to thank the committee again, and to all the central service technicians out there, we appreciate you, and we're thankful for your support. Here, thanks.
Okay, thank you. The chair lays over House File 1883 as amended for possible inclusion in our omnibus bill. House File 2435. Chair Bierman, would you like to move your bill before the committee?
Thank you.
Go ahead, Chair Bierman. Would you
Yes,
like
I'd
to
like
move?
the House File 2435, and there is an author's amendment as well, please.
Yes, I believe you have that A1 amendment to reflect the update recommendations from the administration. Members, we will adopt this amendment to get the bill in the form that Chair Bierman would like. All those in favor of adopting the A1 amendment, say aye. Aye. All those opposed, say nay. The motion prevails and the amendment is adopted. Representative Bierman, we are, go ahead, state and testify.
Thank you, Mr. Chair. And I just wanted to comment on the amendment itself, that it includes several policy proposals from MDH. Allows insurers to provide explanation of benefits electronically. This proposal would allow insurers to send explanation of benefits electronically, paper, or both if members prefer. Also, network adequacy, federal conformity. This proposal aligns Minnesota's network adequacy standards with federal regulations, which is required for state-based healthcare exchanges by January 1, 2026. Also has prescription price transparency, technical fixes and enhancements, and a technical 340B fix. This proposal includes updates to the Prescription Drug Transparency Act and the 340B covered entity report to enhance clarity and compliance. The amendment also includes changes from an earlier version of this bill in the Senate to address concerns from generic manufacturers. Additionally, updated regulation of HMOs. This proposal updates the regulation of health maintenance organizations to align with modern insurance practices and address regulatory gaps. And finally, the hospital closure clarification. This proposal clarifies the procedure for hospital closures and relocations. It specifies that if inpatient health services are moved to another hospital or campus, or if maternity and newborn care services are discontinued, advance notice is required. This amendment also contains all the revised budget changes to appropriation, House File 2435, and clarifies the membership requirements to the Health Equity Advisory and Leadership Council, and strikes some confusing and unnecessary sentence in subdivision 2. We did the walkthrough on this budget before. I do have Ms. Timian and Ms. Bailey here with us today. If members have questions, you have a spreadsheet of the bill as well, and you have treats from Ms. Timian here going around. So very kind.
Looks like she thinks we need to be sweetened up there, Chair
That time
Bierman.
of day, Mr. Chair. Cannot hurt. So, Mr. Chair, if there are questions of members, we have people up here who can answer on either side.
I would like myself Director Bailey, if you could do a 1-minute testimony on this bill, just highlights the changes and so forth from your perspective.
Sure, Chair Backer, members of the committee. Elise Bailey, Budget Director of the Department of Human Services. So the amendment, I'll kind of quickly go over the highlights. We had no new proposals when it comes to DHS in this jurisdiction. However, there are a few changes in the governor's budget as it relates to specific proposals. One is the pharmacy carve-out. Our original proposal had an effective date of January 1st, 2026, and we determined that is too quick to implement, and so it has shifted the effective date out to July 1st of 2026. This has a significant fiscal impact, however, due to timing of payments and buying back MCO withholds and all the wonkiness related to when money flows in and out. And so the resulting impact is only a savings of 3.7 in the first biennium and 15 million in the second, which is much less than what the original budget had. We also are clarifying that the pharmacy carve-out is only applicable to MA, not Minnesota Care. The second big change is the HMO surcharge. In our original proposal, we were just tracking the additional revenue that the state would get by increasing the percentage for the HMO surcharge. However, when we increase that, we also invest it back into the rates for the for the managed care plans that participate in the medical assistance program. And that was a big error we found in our proposal that we are fixing here. So the updated impact of that proposal would be a savings of 136 million in the first biennium and 128 million in the second. There's a few other cost neutral changes or fixing of errors in the amendment. The first part of the amendment goes over the telehealth requirement in our proposal. We're delaying the sunset on audio-only telehealth, and this applies it also to commercial health plans. We're also making updates to errors we've had in the original language, such as there is the surcharge changes applicable to only HMOs, not hospitals, and correct some drafting errors and jurisdictional issues between the human services jurisdiction and the health jurisdiction. And then lastly, of course, the appropriations are changed according to the February forecast. With that, if there's any questions.
Okay, members, questions? Chair Liebling.
Thank you. And this is for Ms. Timian for the Department of Health. So we have recently heard that the department's been hit with some big cuts. And I know this budget was put together before that, and I just wonder if you have anything to say about, you know, the budget given what the department is already experiencing with cuts from the federal government. I know you didn't come prepared to say, but I just wondered if you had any comment on that, because I'm sure that the department's needs now are greater than they were when this budget was put together.
Mr. Chair, members of the committee.
Yes, go ahead, ma'am.
For the record, Lisa Timian, Director of Government Relations at the Minnesota Department of Health. Thank you for the question, Representative Liebling. The announcement from last Tuesday was nothing short of devastating. MDH suddenly lost over $220 million in federal funding that we had expected to not continue forever, but continue for a longer time, and we had agreements in place with CDC, so we've been really reassessing. As I'm sure you saw yesterday in the news, we had to unfortunately lay off over 170 staff. Also, there's additional cuts happening at the federal level to public health, so this is just, in general, a very difficult time for public health. The original and revised budget proposals did include funding for infectious disease work at the department for $1.3 million. This will be basically just a drop in the bucket. I think we are continuing to assess what core functionalities will or will not be able to continue as we go through this unexpected agency reorganization right now. But yes, our needs definitely exceed what I understand is available.
Mr. Chair.
Follow-up, go ahead.
Thank you, Mr. Chair. Thank you for that. I just really want to put a pin in this, because this is the Health Committee. And these things that the Department of Health does are foundational to keeping Minnesotans safe. I mean, we're talking about, infectious diseases, bird flu, measles, a lot of things. And I just want to let folks know, I've been working on a bill to have some sort of emergency funding for the department, but, that's taking a while to get ready. But, this is just really serious. We all have to really think about the foundational things that really Minnesotans have to keep just basic health across the state. And I am very concerned about the cuts that the federal government has made, and somehow some of this we're gonna have to backfill as a state, because we just cannot abandon our citizens and just say, infectious disease, I'm so sorry. Waterborne disease, I'm so sorry, you're on your own. That is just not acceptable. So thank you for that, and I hope that we can all work together and make sure that that our state has what it needs to maintain these things that are absolutely essential for public health. Thank you.
Chair Bierman, can you close on the bill, please?
Yes, and I just do appreciate the question from Chair Liebling, and I just do want to emphasize myself the impact of these cuts, which, we're talking a quarter of the budget of Minnesota Department of Health, and we're talking about losing employees who then, have to have done work that will not be compensated, closing down programs, severance packages, unemployment. This is a multi-million-dollar thing just to have that many people need to be forced out and stop programs. And so there's a ripple effect across the entire agency. Thanks for hearing the bill, and we're working on our budget as we go each night here, and appreciate you hearing the bill, paying attention to these issues, and helping us out. Thank you.
Okay, thank you. Chair Bierman, one clarification, it is 25% of the federal budget for MDH, not the total budget. So I want to make sure every members know of that. Now, the chair lays over House File 2453 as amended for future consideration at a later date. Members, we are in recess to approximately 6:45, where we will be, or the call of the chair, where we will be first taking up Representative Ryer's bill, and then House File 2464. With that, we are adjourned again to approximately 6:45. We are in recess. I'll do that correctly. Thank you.
We'll take adjournment.
No, we will not. We are in recess at 6:45, or the call of the chair. Thank you.